understood that it is a hemicranial headache or partial headache or unilateral headache. Now, interestingly, this headache, it passes most of the times, it has many phases, which we call as pre-headache situation. Then the patient have headache situation, and then the post-headache. Now, pre-headache we call as prodrome. Now, what are the common prodrome symptoms when you have migraine? Yawning, excitability, depression, lethargy, or craving for or distaste for certain foods. When you come to aura, this prodrome may last for say 15 to 20 minutes. And then it is followed by aura. Aura is a definitive warning signal that the headache is going to come. Now, aura symptoms basically include, you could see flashes of light or zigzag lines in front of your eyes, or you may have difficulty in focusing on certain object or reading. And then this could be mild, moderate to severe. And the headache symptoms, when they start, they include anorexia, that is loss of appetite, vomiting sensation. Actually, the patient may vomit also. And then very classical symptoms of migraine headache are photophobia and phonophobia. When you say photophobia, basically you will unable to tolerate bright lights. That is why most of these patients who have migraine, they tend to close their eyes and then shut themselves up in dark rooms, and they cover their face with a blanket and they want to sleep. When you say phonophobia, basically this situation, the patient is intolerant to loud noises. Loud noises worsen their headache, so that is why they become irritable at that time. And sometimes there may be some ringing in the ear. After this, you have the rescue symptoms, and then once the headache subsides, which we will discuss later, there is a post-headache syndrome, which may last from few hours to up to 2 days following the subsidence of the headache. Now, once you make a diagnosis of migraine, you have to choose the direction in which you are going to treat the patient. Now, migraine attacks have two forms of therapies. One is a preventive and one is abortive. So, abortive treatment you give when the patient has severe attack, that is the acute attack of migraine, you give the abortive treatment. But in a patient who has got frequent migraine headaches, we call them a migrainer. Now, if you get these attacks more than twice a week, and if they are disabling, and they are lasting, say, for a day or two, which may last 3 days also. So, these are the conditions where you really have to put these patients on the preventive treatment, because many a times these headaches are so disabling that it interferes with their activities of daily living, their lifestyle, and also their work gets affected. Now, whenever you have headache, the headache history becomes very important if you want to make a diagnosis of migraine. Now, you have to look at what is the precipitating cause. This is important because some people, the migraine may get precipitated by loud noise or bright lights or flickering lights or bright sunlight. And then headache and attack descriptions. Now, whenever somebody has a headache, you look at the location of the headache and how much time it takes for the headache to peak and how long it lasts and what is the severity and if there are any warning symptoms and then associated symptoms and level of disability which the attack is causing. Now, not all headaches are migraine, but headache is one of the commonest causes. Migraine is one of the common causes of headache. Now, what are the worrisome symptoms? So, all headaches cannot be just overlooked saying that it's simple headache, nothing to worry. There are certain situations, certain indicators which tell us what are the worrisome signs of headache. Now, in short, these are called the red flags, and the eponym is SNOO. So you look at the systemic symptoms. If you have severe headache with high fever, it has some implication. You have to look for a condition like meningitis. If the patient has severe headache and is losing weight continuously, you have to look for these secondary risk factors. Now you have to look at the history. You have to see whether the patient is having any immunodeficiency syndrome, HIV, or any history of malignancy. Now, if the patient has other neurological symptoms apart from headache, like if he is confused, he is impaired in level of consciousness. So these are worrisome things. So you cannot just say that this is simple headache and it will go away. It may possibly require a proper neurological evaluation. Now, another situation is sudden onset headaches, abrupt or split second headache, or a thunderbolt headache or thunderclap headache. Now, this sort of headache could indicate a sudden intracerebral hemorrhage or subarachnoid hemorrhage. And then this needs to be evaluated and to be taken severely. So a first time headache or a severe headache or a thunderclap headache or thunderbolt headache, this cannot be, taken lightly. You need possibly to look into as to what is the cause of this event. Now, other situation is elderly patients where they may be having history of headache, but then now their headache has changed its pattern. It has become more severe and has now been associated with added symptoms like vomiting or focal deficit, like weakness on one side and getting seizures. So these situations you need to evaluate as to for the secondary causes of headache. And then especially in the middle-aged and patients over 50 years of age, there are certain treatable conditions like giant cell arteritis. So headache, it is unilateral, but then it has got an underlying cause. So these patients will be evaluated and they can be treated appropriately, because if it is not done in a situation of giant cell arteritis, there is a danger of losing the vision or developing a stroke. Now, if there is a previous headache history, the first headache has been there on and off for quite some time. But now, if the headache pattern has changed, the duration has changed, or the severity has changed, then you need to relook into it. It will not be the same migraine which the patient was suffering from. It could well be something different. Now, a very close contender of this type of routine type of headaches which we all see in our life day in day out, tension type of headache. Now tension type possibly is a close contender of migraine because it is also very as common as migraine. But as I said, migraine is one of the commonest form of headache, following the tension type of headache. Now usually the tension type of headache is mild to moderate, rarely severe. It could be on one side of the head, but more commonly it is on both the sides of the head. And if the headache is, as I said, associated with photophobia, nausea, vomiting, then it is more in favor of a migraine type of headache rather than tension type of headache. And definitely, if the patient has an aura, flashes of light, or has vomiting associated, or aggravated by activity, then it well could be migraine. The other close contender, the headache which looks like migraine, is the cluster headache. Now, this is more common in men above 40, 45 years of age. And then, well, these patients usually have a very prominent blood vessels on their head in the temporal region, which may be pulsating, it may be tender to feel, and then it is severe pain behind the eye in this situation, and then there may be drooping of the eyelid on one side, and there may be associated redness or tearing from the eye. Now, the end usually it has a congestion on the one side. That is why many a times it could be mistaken for a sinus headache. Now, when do we suspect migraine? Though migraine is a very common symptom, when do we suspect? Now, there are certain pointers which tell us that, well, this could be migraine. Now, if there is sensitivity to light or sound, that is called photophobia or phonophobia, or sensitivity to this, or loud sounds or noise can be precipitating these attacks. So, sensitivity to light or sound, it is a migraine. Headache, which is unilateral or alternating headache, that one has history of headache, it could be alternating. That usually comes on the right side, but sometimes also comes on the left side also. So this sort of alternating headache episodes is a pointer towards migraine. Now, if the headache is pulsating or throbbing, like the heartbeat, if it's a throbbing type of headache, then it is a pointer towards migraine. If it is episodic, that if one does suffers from a headache, but then he has got headache-free interval for say few days or few weeks or few months also for that matter, and then again similar type of headache recurs. Now this is a pointer towards migraine type of headache. And if the headache is so severe, the patient is all right, but suddenly when he develops headache, it is compromising the quality of life. Now, in a severe headache, recurrent headache, unilateral headache, throbbing headache, and it may be compromising the life of the patient. This is a pointer to migraine. Then, if there are triggers which can be identified, and as I mentioned, loud noises, sound, or simple trauma or trivial trauma to the head, if it is precipitating an attack, then this could be a pointer to the migraine. Now, by and large, a large number of causes which day in day out which are surrounding us, which include overcrowding which we see in festivals, the education system stress in children, high pollution around us, the pollution with the noise, the smell, the dust, or the sound pollution, a very hot climate. As I said, anything under the sunlight, including the sunlight, can precipitate an attack of migraine. Now, other thing in our country, like the fasting practices, if one fasts, that could precipitate an attack of migraine. Sometimes the incense sticks, the agarbattis, and the fumes which are coming out of this, and the food stuff which we eat, whether it be spicy, oily, fried Indian foods, or then joint family stress or crowded travel conditions, which is very common in our country. Now, these well could be the attacks, the reasons which could precipitate an attack of migraine. Now, coming to the treatment of migraine, as I was mentioning, that when do we treat? Now, we treat the patient whenever he has an acute attack, or which is called an abortive treatment. And if the patient has attacks which are very frequent, say more than twice a week, and it is, as I said, a disabling headache, is unable to attend his job or pursue his studies, then these are the situations where you want to treat them. Now, if the attack, the patient has an acute attack, it is not disabling, short duration, and if it is a good treatment, a good response to the acute care medications, which I'll mention. Now, simple drugs like aspirin, paracetamol, naproxen sodium, now these are the drugs which many a times give very good relief to these patients, provided they can realize that the attack is going to come, and then they can take the treatment at the earliest, at the onset of the symptom. Minimum who they have, I'm going to get this sort of headache, and if earlier they take the medication, preventive medication, then they can get rid of the acute attack. Once the attack is established, then it is definitely going to last for a few hours, and then it is going to be debilitating, and the patient may need to stop his work, then maybe has to go and sleep. Many times a vomit reduces the severe type of attack. Otherwise, a good nap, a sleep, gives them relief when they wake up. Now, preventive medicines have to be taken if the headache is disabling, the headaches are longer lasting, and they are having a poor response to the acute treatment which we give to the patient, which are analgesics, normally the non-steroidal anti-inflammatory drugs. And then if the increased frequency of headache is there. Now, what are the goals of preventive treatment? Now, why do we treat them? Now, recurrent migraine headaches, apart from interfering with the quality of life, may have debilitating effect, and then may also, we could also see some changes in the MRI in the brain. So these severe attacks, if they are frequent, they could be debilitating, and then they may have long-term effects. Not only the headache, they may have long-term effects like they may lead to anxiety mixed with depression. Then these patients may also develop suicidal tendencies if the attacks are very debilitating and severe. Now, the main aim of starting a preventive treatment is to reduce the frequency of the duration and severity of attack, to improve the quality of life, and then reduce disability. Now, when do we consider prevention? Now, generally, as I mentioned, patient experiencing 2 or more attacks in a month, and attacks have severe symptoms that impair the quality of life, impact business, duties, household chores, or school attendance, and then attacks do not respond to acute drug treatment, including triptans, is not responding to, or if there is a contraindication for starting giving this acute attack drugs. And then if the patient is ending up with a frequent use of medication for his headache. Now, whenever we give a tablet, like say naproxen sodium or aspirin, or a combination of caffeine with paracetamol, now these drugs definitely give very good response. But then these drugs, non-steroidal anti-inflammatory drugs, frequent use of this have an addiction potential basically, and we have patients who take these tablets, 2 or 3 tablets or 6 tablets per day whenever they have a headache, and subsequently, the migraine gets transformed. So from the migraine attacks, it changes to a situation where you have a drug-induced headache. Now, if the patient doesn't take these analgesics, he will get headache. So he becomes addicted, he becomes dependent. So it's called a drug dependent situation. And it may be, not good if you are going to take this non-steroidal drug for a long time. Now, there are certain situations, like the patient has a complicated migraine. And this is one situation where you need to treat. Now, if the patient has, say, severe visual loss preceding the headache, or if he has got a weakness on one side, it's called the hemiplegic migraine. If the headache is lasting for a long time, which we call status migrainosus, and if the patient has prolonged aura, so anxiety, depression lasting for quite some time, and then there are certain situations. The migraine is also not uncommon in childhood. We call it childhood migraine or basilar artery migraine, and most of these attacks could be associated with debilitating situations like weakness or drowsiness or altered sensorium, which may last for a long time. Also, there are situations where you can have migraine overlaps. So you could have hemiplegic migraine, and then you could have epileptic headache, which will look like migraine. But then in this situation, the routine migraine prophylaxis drugs, they don't work. Then you need to put these patients on certain drugs, which could be anti-epileptic drugs. Now, the concept stems from, you have migraine 2 types, with aura, without aura. Now, migraine with aura basically means that the migraine process has initiated in the visual areas. So it is causing visual disturbances, and then it spreads over from back to the front of the brain, and then causes these visual symptoms, which include flashes of light or hemianoptic field effects and things like that. Now, this progression of the electrical symptoms will give rise to the aura which the patient has. Now, if this electrical disturbance starts in a silent area of the brain, then you may not have an aura. But then in this situation, only the anti-epileptic drugs could be effective prophylaxis to prevent these sort of attacks. So now there are many group of drugs which we use for migraine prevention, and then of which commonly we use the beta blockers, then we have the calcium channel blockers, and then we have the anti-epileptic drugs. So various drugs which we use in prevention of migraine, these are the common ones. Now, if you use a beta blocker, then in certain situations, in young individuals, maybe it's a very good drug which you could use. And then if the situation is the patient has also associated hypertension, so that is one condition where you could choose a beta blocker because it will help the both. If the patient is anxious with the heart rate which is fast, so if he has tachycardia, that is one situation where you could choose a beta blocker as a migraine prophylaxis. Patients who have anxiety and tremors, so in that situation, possibly you could choose a beta blocker as a migraine prophylaxis. The other, a situation like if the patient is suffering from asthma, then possibly you will not be able to use a beta blocker. Now, other group of drug would be calcium channel blocker. So, flunarizine is one choice because it is very effective in migraine prophylaxis. Now, it's a very good drug, but then side effects of flunarizine could include, say, drowsiness or weight gain. So, these are the two things of which we should be aware. And very rarely, depression is another associated problem with flunarizine. Now, coming to the third category of drug, the anti-epileptic drugs which we use. Now, as I was mentioning of a condition called epileptic headache. So these headaches are severe, they come with great severity, and then you use the preventive drugs in them. Ideally, if you use an anti-epileptic drug, these patients will be benefited by using a drug like sodium valproate or topiramate. The problem of sodium valproate is it causes weight gain. Then topiramate is a very good drug which doesn't have the side effect of weight gain, and it's quite effective in migraine prophylaxis. Now, coming to the point of how do we treat these patients who have migraine, and how long you need to treat these patients with these prophylactic drugs. So, first of all, we have to educate the patient. We have to make them understand that the prophylaxis drug which we are going to use, we may have to use it for a minimum period of 3 to 6 months. And sometimes we have used this for a year or longer. So that is the reason why you have to choose a very appropriate drug which does not have side effects in that particular given patient. Second thing is, most of the times it may be a few weeks, a few months before the patient gets the desired response. And it may be well beyond 3 to 6 weeks before you see a reduction in the number of attacks, that is, severity of attacks coming, the duration of attacks coming. All these things gradually they will settle down. So it cannot be like a magic. It will take some time. But once the response is there, most of them they benefit, but you need to continue the medication. So we have to convince the patient that the preventive treatment which we are talking about has to be continued for quite some time before we can consider stopping the drug. Now, there are a few other things, like patients, especially if you have women who have migraine, have to be warned that they should avoid using hormones and contraceptive pills, especially which they use to postpone the menses and things like that. So it is ill advised to use hormones in women with migraine. And then the drug which they are going to use when they get a severe attack. Also, most of the time the patient knows that this is the drug which I use. Say, some patients they feel very comfortable with aspirin. Some people use a combination of caffeine. Sometimes we have to use ergot preparations. and sometimes we have to use another set of drug called the triptans. So you have to individualize the treatment. You have to see which drug is best suited for that patient or giving good response without side effects of the drug, and then prescribe such a drug for these patients. I think I'll stop here, and then it will be interesting to discuss if there are any questions. Thank you.